Understanding opioids and the crisis of addiction, a comprehensive overview. Opioids are a class of drugs that include both natural and synthetic substances that bind to opioid receptors in the brain and body to produce effects such as pain relief, sedation, and euphoria. The term opioid encompasses all compounds that act on opioid receptors, including synthetic analogs, while opiate refers specifically to naturally occurring substances derived from the opium poppy, such as morphine and codeine. At the neurochemical level, opioids function by mimicking endogenous neurotransmitters like endorphins, binding primarily to the mu-opioid receptor, MOR, in the central nervous system. This interaction inhibits the release of neurotransmitters like substance P and glutamate, effectively blocking the transmission of pain signals. In addition, opioids stimulate the brain's reward pathway by increasing dopamine release in the nucleus accumbens, producing feelings of intense pleasure and reinforcing use. Opioids are categorized into three main types: natural, semisynthetic, and synthetic. Natural opioids include morphine and codeine. Semisynthetic opioids, such as oxycodone, hydrocodone, and heroin, are derived from natural opioids but chemically modified. Fully synthetic opioids like fentanyl and methadone are manufactured entirely in laboratories and can be significantly more potent. Opioid formulations are administered through various routes depending on their use. Common methods include oral tablets, intravenous injection, transdermal patches, nasal sprays, and sublingual films. These different routes affect the onset, intensity, and duration of the drug's effects. Detection windows in drug testing vary by substance and test type. Morphine and codeine typically remain in the urine for 2 to 3 days, oxycodone for up to 4 days, methadone for several days, and fentanyl for 1 to 3 days, although hair tests can detect use for up to 90 days. Pharmacokinetically, opioids differ in their absorption rates, metabolism, primarily through the liver enzyme CYP450, and half-lives. Pharmacodynamically, they share common effects: analgesia, sedation, and respiratory depression, but vary in potency and receptor affinity. Short-term effects of opioid use include pain relief, relaxation, and euphoria, but also constipation, nausea, and drowsiness. Long-term use can result in hormonal dysregulation, immune suppression, increased pain sensitivity, hyperalgesia, and psychological effects such as depression and anxiety. A distinction must be made between opioid dependence and addiction, clinically defined as opioid use disorder, OUD. Dependence refers to the physiological adaptation to repeated opioid use, leading to withdrawal symptoms upon cessation. Addiction, or OUD, is characterized by compulsive drug-seeking behavior despite harmful consequences. According to the DSM-5, OUD is diagnosed based on criteria such as loss of control over use, cravings, tolerance, withdrawal, and continued use despite social or occupational problems. Several risk factors contribute to opioid addiction, including genetic predispositions, e.g., family history of substance use disorders, environmental factors, e.g., trauma, socioeconomic status, and psychological conditions, e.g., anxiety, depression. Tolerance develops as the brain adjusts to the presence of opioids, requiring higher doses to achieve the same effect. This occurs due to receptor desensitization and downregulation. Withdrawal from opioids can be intensely uncomfortable. Acute symptoms include muscle aches, insomnia, diarrhea, vomiting, sweating, and anxiety, typically peaking within 72 hours and resolving in 7 to 10 days. Protracted withdrawal may persist for weeks or months, marked by mood swings, sleep disturbances, and cravings. The brain's reward circuitry, particularly the mesolimbic dopamine system, reinforces opioid use and contributes to the cycle of addiction. Opioids are commonly prescribed for acute pain, post-surgery, injury, and chronic pain, e.g., cancer, osteoarthritis. However, the overprescription of opioids, often beyond what is clinically necessary, has been a major driver of the opioid epidemic. Patients initially prescribed opioids for legitimate medical reasons sometimes escalate to misuse and illicit use. Many individuals transition from prescription opioids to cheaper and more potent alternatives like heroin or illicitly manufactured fentanyl. Diversion of prescription opioids occurs through theft, illegal sales, doctor shopping, and sharing medications. Illicit opioids, particularly heroin and fentanyl, pose significant risks due to their potency and variability. Heroin is often impure and mixed with dangerous substances. Fentanyl is approximately 50 to 100 times more potent than morphine and is frequently mixed with other drugs without the user's knowledge, leading to a high risk of overdose. Common adulterants include xylazine, a veterinary tranquilizer, caffeine, and synthetic analogs, which increase unpredictability and harm. Treatment for OUD is most effective when it combines medication and behavioral interventions. Evidence-based options include medication-assisted treatment, MAT, using methadone, buprenorphine, or naltrexone. Methadone is a full opioid agonist that suppresses withdrawal and cravings. Buprenorphine is a partial agonist with a ceiling effect that reduces overdose risk. Naltrexone is an opioid antagonist that blocks effects if opioids are used. Each medication has pros and cons. Methadone requires daily clinic visits. Buprenorphine has lower abuse potential and can be prescribed in office settings, and naltrexone is best for highly motivated individuals due to required detox before initiation. Therapies like cognitive behavioral therapy, CBT, and motivational interviewing, MI, address the psychological underpinnings of addiction, helping patients develop coping skills, restructure harmful thought patterns, and enhance motivation for change. Challenges to accessing treatment include stigma, limited provider availability, geographic disparities, and financial barriers. Recovery is often nonlinear, with relapse rates ranging from 40% to 60%. Factors contributing to successful recovery include strong social support, sustained treatment engagement, and co-occurring mental health management. Peer support groups, such as Narcotics Anonymous, offer community, accountability, and structure that complement formal treatment. The opioid crisis has profound public health ramifications, including a surge in overdose deaths, increased transmission of infectious diseases like HIV and hepatitis C, and burdens on emergency and healthcare services. Economically, it costs billions annually in lost productivity, healthcare expenditures, and criminal justice system involvement. Legally, opioid misuse has led to widespread litigation, regulatory changes, and reforms in prescribing practices. Harm reduction strategies, such as naloxone distribution, a life-saving opioid antagonist, needle exchange programs, and supervised injection sites, have been shown to reduce overdose deaths and disease transmission without increasing drug use. Policy efforts to combat the crisis include prescription drug monitoring programs, PDMPs, expansion of MAT access, educational campaigns, and criminal justice reform aimed at diversion programs and treatment over incarceration. The opioid epidemic has not affected all communities equally. Rural areas, economically disadvantaged populations, and racial/ethnic minorities often face greater barriers to care and higher overdose mortality rates. Ethical considerations surrounding opioid prescribing and treatment include balancing pain management with addiction risk, ensuring equitable access to care, and navigating consent and autonomy in harm reduction programs. In conclusion, addressing the opioid crisis requires a multifaceted approach: scientific, clinical, public health, and societal. A clear understanding of opioid pharmacology, addiction science, evidence-based treatment, and the broader structural and ethical challenges is essential to mitigate its devastating impact.